Okay, for those who don't know me, my name is Roger James, and I'm the chair of the Trinidad and Tobago Healthcare Youth Forum, commonly known as TUF, TTHUF. And you should be able to see my screen. We are a registered charity in England, and we are made up of healthcare and other professionals who have affiliations, born or otherwise, to Trinidad and Tobago. And we are committed to improving safe and effective healthcare service provision, primarily in Trinidad and Tobago, but elsewhere if the opportunity arises as well. And we do that by contributing to improving safety and effectiveness of healthcare in Trinidad and Tobago so that people receive treatment that is quality assured and evidence-based. And we have a few links up there for those who haven't been visiting our website, and you can email us, and we're on social media on Twitter and Facebook for those of you who like doing those things, LinkedIn. And we just set up a YouTube channel where things like this video will be posted. Okay, so enough about me. I'm going to start now by saying, so tonight, this is our second webinar. We're going to be talking about nursing in Trinidad and Tobago. And we have two eminent nurses in Trinidad and Tobago joining us on our panel. And I'll allow them to introduce themselves shortly. Just to say, the first one is Dr. Oscar Ocho, who is a director and senior lecturer at the University of the West Indies School of Nursing. And we have Edie Stewart, who is the president of the Trinidad and Tobago Registered Nurses Association. So I'll first start off with Oscar. Oscar, can you hear me?
Yes, I can, Roger.
Okay, so Oscar, please introduce yourself. Tell us a bit about your clinical background, what you've done to date, and what is your current role?
Great. Well, thank you so much, Roger, for having me. And as part of the panel with my colleague, Edie Stewart, I started off my career in 1981, actually, at San Fernando General Hospital as a nursing assistant trainee. And so I moved from there in 1984 after enrollment as a nursing assistant. I started general nursing and completed my training with one of my batchmates, whom you know very well, Mrs. Betty Ann Pilgrim.
Yes, I do.
We were in the same study group. So we qualified in 1987. My career path was extremely interesting and exciting. Within 3.5 years, that now was in January 1991, I was sent to Staff Development Unit. So I worked at Staff Development Unit at San Fernando, and then I left. I went to Jamaica, did my certificate in nursing education, came back, worked at St. John's Hospital as the coordinator of the nursing assistant training program, then shifted to Staff Development Port of Spain as a nursing instructor, went back to Jamaica, did my bachelor's, returned as an instructor at NEHURST then, which is now COSTAT. And then I left nursing in 1998, and I spent 16 years in public health as the health education officer for 2 years and director of the population program unit for 14 years, after which I spent 6 months as the chief nursing officer. And that's where I ended up at the university now as the director, senior lecturer in nursing.
Okay, lovely, very extensive and very experienced career. So thank you for that introduction. Just before I introduce Edie, I'm going to mute everyone and unmute the speakers because I can hear some background noise. And if you want to speak, then you'll need to unmute yourself. I think that's how it works. Yes, I think so. So let me unmute Edie. And Edie, can you unmute yourself, please?
Yeah.
Okay, right. So, Edie, similarly, can you, for participants, introduce yourself, tell us about your career journey and what does your role currently involve as president of TTRNA?
Thank you, Roger, and thank you to Tuff for having me, to being on this panel with Dr. Ocho, the esteemed Dr. Ocho. I'll be brief. My career path is not as extensive as Dr. Ocho, so I would have started nursing in 2002 and graduated in 2005 in mental nursing. Spent several years at St. Anne's Hospital. Proceeded to do my bachelor's in oncology nursing. Spent a few years at the St. James Medical Oncology Department. Went on to do health administration, well, qualifications in health administration and industrial relations, and eventually landed as the president of TTRNA in 2016, where I have been since. So between 2016 and my term is supposed to end in 2022. So that's basically it for me.
Okay, and just to clarify, as president of TTRNA, is your role primarily representing nurses? Because I think that TTRNA has a dual role as a union and a professional body, is that right?
Right, so let me talk about TTRNA for a little quick sec. TTRNA, founded in 1930, started off as the Certified Nurses Association of Trinidad and Tobago, way in San Fernando, and it progressed over the years until the current body called Trinidad and Tobago Registered Nurses Association. Although we actually have taken a decision to change the name of the organization to Trinidad and Tobago National Nursing Organization, because we now encompass not only registered nurses, which where we started off from, but all categories of nursing personnel as identified by the ILO Nursing Personnel Convention and ICN, where they recognize 3 categories of nursing personnel. So the professional nurse, which would be the registered nurse, mental nurse, district health visitor, all of those persons. Then we have the supportive and the auxiliary. So we also represent enrolled nursing assistants and patient care assistants currently. Non-governmental, independent, voluntary, largely. The only full-time officer, we have 6 officers in the association. The only full-time officer currently is the president, and we are bringing on, as finances permit, we're bringing on persons. So the next person we are bringing on would be the second vice president, who is actually here with me, listening into the call right now, Ms. Letitia Cox. So we cover all categories of nursing personnel, both public and private institutions. Yeah, so that's in a nutshell, TTRNA.
Okay, so you're now the TTNNA, basically. Okay, lovely. We'll hear more about that in a minute. So Oscar, are you back with us?
Yes, I am. I just changed back to my desktop.
Okay, lovely. Okay, so we decided we're going to talk about nurse leadership and nurse education with yourself. So if I'll start with you first and talk about nurse leadership. It's been a topical discussion around the world, and I know Trinidad and Tobago has been having conversations about it. So from your position, Oscar, can you define what is nurse leadership and what is their role as a nurse leader, and what is the current profile of the term and practice of nurse leadership in Trinidad and Tobago currently?
No, it's interesting that you asked me to respond to a number of questions in one question.
Sure.
And if I would start with just defining leadership, it's about influencing others to walk a path that at the end provides a mutual outcome. If I'm to put it very simply, nurse leadership is extremely complex simply because we are operating in a system that is still highly medical in nature, in that there is still the hierarchical focus, and yet you have nurse leaders who are positioned at the policy level, and very often the voice at the policy level is not as respected as the physician who has to articulate the positions for the position of the medical fraternity. And I'm putting that within the context of the Global Advisory Panel on the Future of Nursing. And if you look at that report, throughout the continents, GAPFUN has agreed that the #1 issue affecting nurses is the whole idea of leadership. And it is clear that even though sometimes nurses are given the positions, they are not necessarily given the requisite authority and respect to be able to effectively provide the mentoring, the nurturing, and the level of support as it relates to transitioning of other persons and preparing the future to assume positions not just at the clinical level, but also at the policy and at the middle management level.
Oh, I see. Okay. That's a comprehensive answer. So thank you for doing that. So with that definition and the role, what in Trinidad and Tobago currently, how high a profile is it? That taking into consideration all you have said about a hierarchical structure and maybe whilst given the administrative position not being supported to make decisions, well, how high is the profile and who is driving raising the awareness of the importance of nurse leadership?
Yes, the challenge in Trinidad and Tobago is unique and complex. And I say unique simply because when you look at the organizational structure, there is a chief nursing officer whose title is now National Administrator for Nursing Services. But although there is that wonderful title, that chief nursing officer provides supervision to absolutely no one in nursing in the country. So it's a nice administrative title, but functionally, there is no administrative function. So you operate at the policy level.
Right.
And one has to depend on your own personal suasion as well as your experience to cause now the general managers nursing who would operate at the regional health authority level and who are accountable to a chief executive officer. So that as the National Administrator of Nursing Services, you cannot provide any scope of works, for example, for a general manager nursing. You have no locus standi as it relates to the performance management of a general manager. So you now are technically, and I could speak because I have sat in that position with this level of complexity. You have to provide leadership in an environment where your voice is the one single voice for nursing, because the entire structure that was nursing leadership, you are the chief nursing officer, director institutional nursing, director community health nursing, director nursing education. You no longer have the middle management who would be providing leadership, and the tentacles would be spread at the operational level. So because you are there as the chief standing still, it's important then that in order that you can be able to function optimally, it's about knowing how to build relationships with key players and having certain core leadership or management competencies in order to navigate a lonely road and yet come out looking and smelling like a rose.
Right. Okay. Thank you very much. And just to say as well, please, if you have any, all participants have any questions for our panelists, please put them in the chat function. My colleague Caroline will be reviewing them, and we'll read them out periodically. And we will have time for some direct questions as well as the evening goes on. So I just must say that to you all as well. Okay, so having said all of that, Oscar, so that's at a very senior level, and you've given the dynamics involved with that. What about on the wards? What system is there in place for identifying and developing nurse leaders in the country? Those individuals who may be seen as talented, ambitious, and have the necessary requisites who could go further. What program is there in Trinidad and Tobago for fostering that talent?
The reality is there is no standardized program. It is more ad hoc in nature, and depending on how visionary the nurse manager is and how all embracing in searching for new talent and identifying new talent and providing opportunities, that's how it works. Now, what is interesting and the opportunity we have is that we have just gotten a paper published in the Journal of Nursing Management. And that is a piece of work that we did looking at the transitioning of nurses into positions of leadership. And some of the things that were very, very clear to us coming out of this paper is that one, very often there isn't a succession plan for nurse leaders. Secondly, there's an absence of mentoring, effective mentoring and support. While, for example, people may know who their immediate supervisors are, sometimes that immediate supervisor may not be able to provide a level of technical support. So very often people have to learn through their own mistakes. It's a learning curve. What we propose to do with this data is develop a policy map, okay, or policy paper that looks at how do we transition nurses into positions of leadership. And we are looking at things like ensuring that at least 6 months to 1 year before a person is moved, let's say from head nurse to supervisor, or goes on retirement, there is an opportunity for placing that potential successor under the wings and arms of an immediate mentor who could walk them through. We also talking about ensuring that people are exposed to leadership and management training, because with the complexity of the health systems, you are dealing with a different mindset of the workforce. People who are just there to receive a salary, whereas a lot of those who were in my time, and I see Stephanie shaking her head, we did this as a vocation. It was not about the money, but our passion, but yet the money came. So how are we going to get supervisors to motivate individuals who are themselves just using nursing as a stepping board to get maybe to the metropolis or to some other profession? So it's about getting that mentoring and that supervisory support from policymakers making deliberate decisions to ensure that there's continuity of quality leadership at the operational. And if you get that right, then your middle management will become right. And then your leadership, because it means up to the top, because people coming through the ranks will be coming through with core competencies, and they are building on it as they develop further.
Okay, lovely. Lots to ponder on that, and we're going to come back to you and on some more questions on that. Caroline, are there any questions on the chat on nurse leadership for Oscar?
There are no questions as yet, so please put your questions in. We will read them out.
Okay, fabulous. Okay, Oscar, we'll come back to you, and we're going to talk also about nurse education in a minute, but I want to bring Edie, who's been quiet. Edie, the question I'd like to start with you is, I mean, it's been in the news. The TTRNA, or as TTRNA, has been in the news. And nursing has been in the news for all sorts of different reasons. Tell us, what's the state of nursing in Trinidad and Tobago from where you sit at the moment?
Thank you, Roger. In the association's point of view, and in my point of view, we have a Herculean task to drag nursing into the 21st century in Trinidad and Tobago. On all fronts, Dr. Ocho touched on a few of the areas that we need to work on, but it's a massive task, but it's a task that we must fulfill for the health sector to function effectively. One of the major stakeholders, the major pillars must be nursing. It must be done on. So I think once you could improve nursing in Trinidad and Tobago, you could improve the health care, the quality of health care. And on this particular point of leadership that you engage in, Dr. Ocho, that is a sore point specifically for me, because I rarely witness on a daily basis the absence of strong nurse leadership in Trinidad and Tobago. We engage repeatedly, sadly to say, on nurse who's supposed to be nurse leaders, and they have not lived up to the expectations of their juniors. They have not lived up to the expectations of people who would want to mentor them. This leads into the poor succession planning, where you learn incorrect practices by your nurse leaders and then you repeat it.
Sorry, Edie, sorry to interrupt. Sorry to interrupt, but to make it live for me and for others on the call, when you say nurse leaders haven't lived up to their expectation, can you give us an example just to make it, because that could be a broad thing. I mean, obviously you're keeping it anonymous and not identifying anyone. But what would you see as examples of behaviors which you would consider not living up?
One example I repeatedly use, because it kind of solidifies everything, contextualize everything. When I go into meetings with whoever it is, you'll have, if it's the CEO and whoever representative nurse leader would be there in whatever capacity, you would find that if it's the CEO, the HR manager, the IR manager, they'll be speaking, but the nurse leader, whoever that person is, will be silent throughout the meeting. and not really inputting in the conversation only when they are called upon. And when they are called upon, they would not give an opposing view to the CEO. They would not even try. They would always go along saying yes, even though they may know that it's a grave issue in the hospital, the ward, whatever, but they would not dare go against what the CEO or whoever it is. It's not just only in the RHAs or in private, it's straight across the board. And we see it repeatedly. Actually, we were in a meeting with one of the CEOs and the nurse director on the board, who is above the CEO. The nurse director on the board is above the CEO because she's part of she's with the chairpersons and all of that. And she bluntly stated, what is the push? Why the association is demanding nurses get a degree? You don't need a degree to do a bed bath. So when you have nurse leaders like that, who are the most senior levels in the institution, and if that is the mindset of these nurse leaders, why does nursing personnel need a degree as entry qualification into the profession? Then you could only imagine what discussion we'll be having behind closed doors when the union is not there or when other persons. Because if she's so comfortable to say that, why nurses want to continue their education and why you need a degree? You don't need a degree to do bed bath. You can only imagine why nurses are not called upon to fill key positions within the institution, because TTRNA, like the ICN, International Council of Nursing, is pushing for nurses to fill not only nurse leadership positions, but positions throughout the health sector. So why not the quality manager shouldn't be a nurse? Why not the COO or the CEO shouldn't be a nurse? So this is why we're pushing, but we could understand why there's so limited number of nursing personnel in these key positions. I mean,
so can I, sorry to interrupt again, Edie, are you saying, sure. Sorry, are you saying other than the nurse director on the board, nurses don't traditionally hold any other positions in health authorities like the CEO or the chief operating officer or so on, you're saying?
Correct.
Are they not allowed to apply or do they apply?
Yes, they can apply.
Okay.
Yes, they can apply, but they have limited themselves. And while I'm generalizing, obviously there'll be the persons who could come out of that box that I'm trying to, just for the reason for the discussion, trying to just give a general perspective. So there are people who have been able to migrate out of that box. So for instance, it's only recently that we have had, for the first time ever, a chairman of a board. In the RHAs has been set up 26 years now. We have 5 RHAs, and the first time ever we have a chairman of a board who is a nurse. A distinguished nurse leader, Ms. Valerie Allen Rawlins. But it's the first time that has ever happened that you have such a senior person holding that portfolio. We have never had a substantive CEO as a nurse. We had on 1 or 2 occasions a nurse holding the acting position of a CEO, but never really confirmed in that position. Whenever the changing CEOs, they may just put the nurse, because they very well know the nurse has a appreciation of all that is happening in the healthcare sector, but they're probably concerned that they're not occur with some of the logistics, some of financing issues, and it's not really taught in the schools. It's definitely not taught in the schools in terms of all those logistics, dealing with procurement, dealing with all these different things. It's not taught in the nursing schools from the basic level or even at the advanced level in Trinidad and Tobago. So I could understand the inhibition by the top level brass of the RHAs to not want to place them, but it's really unfortunate. Even when you look at the Ministry of Health, are nurses holding some of these positions in the Ministry of Health other than direct nurse positions? And sadly, the answer is not at all. I think there's only about 1 or 2 persons who are nurses by profession holding other positions within the Ministry of Health. And as I said, it's translated throughout the entire health sector, where nurses are not really seen in that light. And that is one of our main challenges to really push forward.
Okay, Edie.
I mean,
so I want to move us on slide, please. So that's at the senior level. In terms of the front line, from where you sit in the TTNNA, do Trinidad and Tobago have enough nurses on the wards, on the front line, in the community to deliver care safely to patients and the public?
Well, absolutely not. Absolutely not. And we have these statistics. First to begin is a couple issues. One, we would have a Stafford establishment approved by cabinet for each RHA. So we have 5 RHAs. Only 2 of those RHAs are at their cabinet approved Stafford establishment figures. So for instance, you would have Southwest. They're supposed to have 11,034 nurses as approved positions, cabinet approved positions. But you would understand that Southwest has been increasing services, like all other RHAs have been increasing services. NCRHA, they have increasing services. They have over 6 hospitals under their remit. However, in the NCRHA, they have not even reached their staff and establishment figures. They haven't even reached that amount. Far less for expanding the staff and establishment to cater for all these additional facilities. The Couva Hospital, the new Arima Hospital, several health facilities. And that poses extreme challenge for the association and healthcare, because you have, I know we are not speaking on government, but we must bring them in to really understand. When we bring up the issue of safe staffing levels on our nation wards, because you could go on to a ward in Trinidad and Tobago and witness 1-2 nurses taking care of 24 patients. That is normal. That is normal. Or you could go on a night shift and see 1 nurse and an auxiliary staff or a supportive staff. 1 nurse, 1 professional nurse, and an auxiliary or professional staff. And
sorry to interrupt, Edie,
normal.
but I think, sorry, Edie, but for context, I mean, you might need to say the type of ward, the acuity level of the patient.
It matters not. It matters not in Trinidad and Tobago. It matters not. Other than ICU and maybe HTU to some extent, or pediatrics, all the other wards are treated as normal. In fact, we're not as rigid as probably before, where you would have a dedicated medical ward or a dedicated surgical ward or a dedicated cardiac. It's not so anymore in Trinidad and Tobago. Wherever there's a bed, you place the patient there. So that is where we are at in Trinidad and Tobago. So you could be on a normal medical ward taking care of an ICU patient on that ward. That is how it goes on in Trinidad and Tobago.
I'm sorry, Edie, again,
So
I'm sorry to be so interrupting. What about mental health? You know, how the nurse patient ratios are analyzed and reflected on mental health wards?
Well, the mental health wards in, predominantly St. Anne, San Fernando have 1 mental health ward. Well, there's no maximum numbers for these wards. These wards, and how to analyze it. Some wards, they have 24 beds, so they go up to 24. It doesn't matter how many nurses, although to be truthful, the St. Anne's Nursing Administration, they have taken a decision to have no less than 3 nurses on any given shift. So that particular region have been trying to do that. To try to say no less than 3 professional nurses on any given shift.
Okay.
They don't always get it. They don't always get it, but at least they try. Unlike Southwest have tried it to some extent, but some other regions you could basically have one nurse on a ward. With mental health again, you could have, there are certain wards in in St. Anne's where you could have up to 60, 70 patients and 1 or 2 nurses on a ward. I mean, anybody who visited there would know that, would see that.
Yes,
That
and
is our ongoing thing. I
clearly
know
no one
there's
could say that's a safe arrangement, isn't it?
definitely.
But can I also come in here?
Yes, Oscar.
Because I think this conversation is a very important conversation that should provide us with an opportunity to look at how we reframe our arguments going forward. Because if we are talking about staffing, and clearly PAHO WHO was right with their theme, safe staffing saves lives. And the reality is there is sufficient evidence to show that depending on the acuity level of the patient and the nurse-patient ratios, it has implications for quality outcomes, discharges, and so on.
Yes.
And therefore, when in Trinidad and Tobago, we have to start looking at not just raw numbers, but how does patient acuity demand a certain level and staff mix to ensure that we have certain outcomes. So that just having 20 patients on a ward doesn't necessarily mean that we may need 4 nurses. But depending on the patient acuity, that will determine now the configuration of the staff. And unless and until we begin to have these kinds of conversations that are rooted in what the evidence is saying, because people don't just want us to be talking in very vacuous. They want us to show how does the evidence contribute to X or Y or Z.
Okay.
And I think this is part of the conversation that we need to have.
Lovely. And Edie, I will come back to you on the state of nursing because but I think based on what you've just said, Oscar, are those conversations taking place anywhere in the country at the moment?
Not that I am aware of. It could be, but I'm not at the clinical level.
Okay.
Edie might be in a better position to respond.
Sure. Edie, are these conversations about what Oscar's just mentioned about staffing numbers, ratios, dependency, acuity, etc.? Are those conversations taking place anywhere at the strategic level in Trinidad and Tobago?
Well, every single time we meet with the RHAs or meet with the Minister of Health, or as we did yesterday when we met with the Prime Minister and told him about some of our issues that we would want to be addressed going forward. We mentioned this issue. We have a long paper trail in terms of this issue, safe staffing. We analyzed everything, we contextualized. If we have done all the work, what we need is the political will and the pressure from groups such as TTRNA and others. Yes. So, as I said, we continuously have these discussions. As I said, we have a long paper trail. So what we realize we have to do is target the persons who can make a difference. We have been targeting the nurse leaders. It has not been resolved. So we are targeting the policy makers. Unfortunately, the nurse leaders are not part of that discussion. So we going direct to the politicians on both sides of the aisle to really get them to understand that healthcare is not building new hospitals. You can never achieve quality healthcare just by building 4 additional hospitals. So we're trying to move them into what the WHO is saying, focusing on primary healthcare, keep persons outside, out of the hospital, rather than building new facilities, which we cannot properly staff. And so if we are short-staffed currently, imagine when these 4 new hospitals come on track and they're trying to supply. And the Ministry of Health constantly reminds us, anytime we're in a public forum, that the healthcare budget, 80% plus is on recurrent expenditure in terms of paying salaries. So they are limited in what they could do. Yet they find the money to build more hospitals, which will even balloon the human resource requirements and the overall expenditure. So
Yes,
we're in a very slippery slope in Trinidad and Tobago. We're in an unsustainable healthcare model where more people get sick, we build more hospitals, create more bed space. We are very unsustainable health. And we actually approaching the WHO levels in terms of what percentage of your budget should be allocated to healthcare, and WHO say, about 10%. We are at that level right now in 2020. We actually at around just below 10%, 9%. And that is before we built those 4 hospitals, Point Fortin, Arima, Sandy Grande, and Roxborough. So we are bringing 4 additional billion-dollar hospitals on stream, and we're already at close to what WHO, the max amount. We have moved between 2014 and 2020, 6 years, we have moved from 4.3% of our national budget spending on healthcare to almost 10%. Have persons experience the benefits of that 5% increase in healthcare budget? The population could answer that. But in my point of view, in walking the wards and getting complaints from nurses, from patients, it's my humble view, we have been spending the money not in the right places. Ever since there was specific
sorry,
Oscar.
Sorry, Edie. Sorry, Edie.
Not treated with those issues. Healthcare financing was one of the issues we were supposed to focus on. Leadership and governance was another area. Technology, all of these areas were identified in the 6 areas of health sector reform. We only focus on decentralization. So now the service delivery have moved away from the Ministry of Health to the RHAs, and that is all that really has been done. The software, we're still doing paper-based. To be fair,
okay, sorry, Edie. Sorry to interrupt again, but Oscar wanted to come in.
Priorities going forward.
Am I on mute?
In terms of getting that software.
No, we're hearing you.
Oh, Edie, can you? I don't think Edie is hearing me though.
That is currently now, except for Tobago. Tobago is gone somewhat.
Sorry, Edie, can you hear me?
St. James Oncology has gone.
No, he's not hearing me.
On that route. Are you hearing me?
No, I am hearing you, but I wanted to interrupt for a while. And can you hear me?
1 second. I may have to restart.
No, we can hear you, but you can hear me?
I'm not hearing you.
Okay.
I'm barely hearing you.
We are hearing you, Edie.
But it's important, Edie, that you also hear us. Otherwise, you will keep talking, okay, and we won't be able to
come back because a call came in, and every time the call comes in, that happens.
Okay, so dial out and call back in, Edie. I think Edie might have to just dial out and dial back in. But Oscar, you wanted to come in, because I wanted to ask you. Yeah, go on.
I wanted to put what Edie is saying in a particular context, because it's important to understand that the framework, the policy framework, which was that document developed by Health and Life Sciences, a UK-based company, which set the roadmap for health systems in Trinidad and Tobago, was entitled Towards a Healthy Nation. And the emphasis in that document was on primary health care. You would be shocked to know that the first position that was gotten rid of in health sector reform was the director of community health nursing.
Right.
We are the policy dialogue, the policy framework that we adopted and accepted. We said, take services to the people, by the people, keep people healthy, ensure that they remain out of hospitals, because we all want the health for all by the year 2000. And that critical position was removed. So we have gone back now, we have reversed to the pre-1978 alma mater, where the focus is on illness. Because I guess from a political point of view, it is more savvy to speak about reduced waiting time and how many surgical operations that we would have done rather than keeping people out of the institutions. So except there is that critical political will to ensure that we invest in keeping people well, invest in ensuring that at the primary care level, we have the community health nurses, we have the community social workers, the community mental health officers. We have the multidisciplinary team of persons who can now invest and impact on the lives of individuals, because part of our conversation has to be, how do we get to interprofessional practice? Because we are dealing with individuals with comorbidities, psychosocial issues, mental health issues, socioeconomic issues, and all of those are going to impact on one patient who is coming from multidisciplinary care. So the conversation has to be about, where have we moved from a policy position that was clearly articulated to a position that is so far from what we have articulated to now dealing with a ministry of illness.
All right. Okay. Okay. Very well put, Oscar. Edie, are you back? I'm not sure. He did die.
Roger, he is back.
I'm back. Yeah.
Okay.
He is back.
Fine. Thank you. So, Edie, sorry about that technical issue, but we just want to move on now. So, one of the things, Edie, now we picked up that clearly there's increased hospital being built, and therefore there's going to be a requirement for more staff. You don't need to be a genius to work that out. Because if you don't close hospitals and you open new ones, you clearly need more staff, you need more equipment, you need all sorts of different resources. And then you haven't mentioned, but we have to also factor in, there will be people retiring, there'll be people leaving the profession for different reasons, there'll be people emigrating, there'll be all sorts of other factors which will be affecting the attrition of the nursing population. So if I can then bring us to this question then, Oscar, how does the nursing, the pre-registration nursing education cater for the increased demands of the nursing establishment?
All right, excellent. Now, part of the challenge we face is that as a region, and I'm saying region, CARICOM region, CARICOM has accepted that the entry requirement for nursing is at the bachelor's level.
You need to have a degree before you can begin your nurse training.
No. You need, in order to enter as a beginner practitioner, you need a bachelor's degree. That is what CARICOM, heads of governments, have agreed to.
Okay.
The reality is, in most of the islands, including Trinidad and Tobago, that is not reflected in law.
Okay.
So you have, while a lot of the islands, including Trinidad and Tobago, have moved nursing education to the tertiary level, in Trinidad and Tobago, we still have nurses graduating, doing the same examination, which is the regional examination for nurse registration, one who is graduating at the diploma level, one graduating at an associate degree level, and one graduating at the bachelor's level. The structure...
How is that defensible? They're doing the same exam, but getting 3 different qualifications.
Exactly, because, again, we make policy agreements and we sign on the dotted line, but there is inertia and lack of political will to translate it now into law. Because if you're preparing nurses at different levels and you still have a lot of practitioners who are satisfied to speak about the apprenticeship type system is still the best system, when you have the literature that is very clear that a more qualified nurse is a more competent nurse, because you are no longer focusing on just the skill. You are focusing now on what are the core competencies in clinical decision making, in communication, in leadership, in professional development. This is not just about giving you more theory, but it's about ensuring that at the end of the day, this person who would have left this program, this training, this institution is coming out good at the head level, but that affective domain is still so very critical, because the essence of nursing is not how bright you are, but on the quality of care you would give to that person regardless of who he or she is. But you are bringing now a body of work from the various sciences to impact on how you deliver that care. And I think because of the disparate programs that we have, there are sufficient, and not sufficient, I should say, there are a number of challenges that we have to contend with as it relates to the quality of the practice based on the quality of the qualification.
So can I just clarify, and maybe other people on the call as well, can you explain the schools of nursing in Trinidad and Tobago that provide pre-registration nurse education,
right,
and what qualification on graduating each of them provides?
So we have the Ministry of Education doing the diploma in general nursing or the diploma in psychiatric nursing. That's 3.5 years, and it is still the apprenticeship type program where you have the classroom and the clinical. Learning as you go, so that's the diploma. You have COSTAT, which is the College of Allied of Science, Technology and Applied Arts of Trinidad and Tobago. They offer the associate degree, and they are still in wonderland about whether they would continue the degree. That is a program that could have any length, because the structure of the program is as such that it depends on where the courses are available. You are able to access the courses. So while it should be a 4-year program, you have persons who could end up 6 and 7 years before they would have completed the theoretical and clinical components of their program. University of the Southern Caribbean and the University of the West Indies, we offer the bachelor's in nursing. But even when you look at the curriculum, you would realize that for UE, there is a lot of emphasis on the medical and social and biological sciences. But you may also have, at USC, there is a lot of life sciences courses that persons will also have to take part because of the ethos of the institution. So while they are core parts of the curriculum, there are different areas of emphasis as it relates to what constitutes the degree. And while all of that is happening, we have a curriculum agreed on model curriculum.
Right. Okay.
It's extremely complex.
It's very complex, Oscar, but can I just ask though, with those 4 schools of nursing and what Edie was saying about the staffing needs requirement, who is doing the work to say in 3 or 4 years time, we know we would, based on attrition and retirement and immigration, we would need 5,000 nurses.
Right. The Ministry of Health,
Okay. Fine.
has the manpower unit.
Okay, so is it possible, question to both you and Edie, the Ministry of Health in their manpower unit knew they'd be building these hospitals and therefore increase the intake of students so that in, like 4 years ago they did this. So by now graduating, there will be an increase in nurses, therefore to supply these new hospitals. Is that possible that was done?
Now, the answer to that question is quite complex. There is one department of health policy research and planning, but the data from the Department of Health Policy Research and Planning is not necessarily the same data that you use for your manpower planning. You have to also appreciate that within the context of our region, policy decisions drive health decisions. So if the emphasis for a particular minister is on let us build more institutions, or we are going in the direction of primary health care, that is what is going to drive now what the human resource does. But the reality is, you will find there are instances where, for example, we would have had IADB provided a loan. There was a document that was prepared, but you still have, within the context of the regional health authorities, you have establishment positions, and you're talking about this is what the establishment is. But then you have RHA approved positions. So sometimes you would have 2 different streams to determine what your human resource needs should look like. And that creates a certain level of complexity for the Ministry of Health's manpower planning unit. Now, they're trying their best because Jennifer Andel, who heads that unit, really tries and she reaches out to institutions. Take, for example, based on the projections as it relates to more than 60% of the community health nurses are 60 and over, or will be 60 and over within the next 3 to 5 years. That's why 100 community health nurses are going to be trained by UWI. We now have 50 and we'll start another 50 in January. So there are opportunities when the manpower unit helps to drive some of the policy decisions, but there are also very often where the policy decision is driving how the manpower unit is going to respond to a policy directive.
Right. Okay. As you said, it is complex, and I'm conscious of the time, and I want to get in a couple more questions. Edie, I will come back to you. But so, Oscar, you deal with pre-registration nursing, is that correct?
And post-registration as well as masters.
Okay, so tell us about post-registration, because that's one of the things that fascinates me. That, you know, if you qualify as a nurse, there is no mandatory requirement for you to do any set of training and updating post-qualification. Correct me if I'm wrong, but that was my understanding. Some
you're right.
do it on their own volition. There is not an employer requirement or a nursing council requirement that there are these groups of training, you might call them mandatory training, statutory training, whatever, a list of what you do periodically to keep updated, to ensure your practice continues to be safe, continues to be current, etc., etc. What is the position with regards to post-registration, mandatory or statutory or essential, whatever you call it, training for nurses in Trinidad and Tobago?
For years, we have been talking about that issue, even at the nursing council level. And as far as we are aware, in the last iteration of the nursing council, we were told that the regulations were being revised to cater for this. The reality is, none of us know where we have reached. So as it is now, there is no requisite for or prerequisite for continuing professional development as a prerequisite for continuing registration.
Right. Okay. So Iggy, in your position as the TTRNA, what's your view on this in terms of either continuing professional development or mandatory training for nurses and making it a requirement for their practice and registration?
Yes, again, one of the major issues TTRNA is dealing with, it was also brought up with the Prime Minister yesterday also. So in Trinidad and Tobago, you do not need to, as Dr. Ocho indicated, you do not need to continue education. I know Ms. Pilgrim, the Chief Nursing Officer, National Advisor for Nursing Services, is actually working on a document for revalidation. I also am part of a group, all the association, the Psychiatric Nursing Association, the Midwives Association, and TTRNA have sat down with the appointees of council. And I just want to reiterate, there's really no council currently. It hasn't had a council since April of 2019. There's appointees of council, the elected persons are not there. Sat down about 2 weeks ago and have agreed to present one united document that would be supplied to the incoming Minister of Health for his intervention, well, to make it into a bill to go before Parliament. So that's a good way forward. All the associations and the appointees of the council. So we are working on that, and hopefully that could be done as a united front that everyone agrees to. And the basic things, bachelor's in nursing education as the entry requirement. And just to point out with regards to the Ministry of Health program, is a certificate you get. It's not even a diploma. It's a certificate in nursing, because I came out of that school and it's a certificate, it is called. With regards to COSTAT, I know I'm jumping up, but I'm just trying to cover so many points before Roger cuts me again. With regards to COSTAT is actually taking a backward step. They were at the degree level, and now they are reverting to an associate degree. And I must point out these issues, again, these are political issues. These issues go beyond where nurses sit. So that is why we always have to be lobbying the governments and try to get these things addressed, because nursing public is asking TTRNA, we want higher salaries, we want all of these different things, we want to be included in the decision table, but as long as we remain in these multiple entry points into nursing in a small island state like Trinidad and Tobago, it may be good for the other countries, but a small island state where CARICOM has already decided on this issue, where all other Caribbean countries have already reached that level, except Trinidad and Tobago and Guyana. We need to keep pushing for that. So revalidation, continuing education, and bachelors, those are three basic things we want to see get into the Nursing Personnel Act. And let me say, the Nursing Personnel Act, after much agitation over the years by some of my seniors to get that antiquated act changed, which was the Nurses and Midwife Ordinance, it was only changed because of political pressure by a small group of persons. And that's how we end up getting the whole nursing turn, which is a kind of oxymoron when you try really understand what an intern is, where we now have persons who, if you do not even write the Nursing Council exam, the regulation exam, or you fail the exam, you still now are allowed to practice in our hospitals. So that is where we are at.
Sorry, Edie, can I just interrupt something? Practice as a registered nurse?
Practice as a provisional nurse, they call them, but you do everything as a nurse. You just have to have someone supervising. Well, supervises.
No, Edie, you got a provisional license, but you are called a nurse intern.
Right. Well, but you do everything as a nurse. There's nothing you don't do. And we would have witnessed this on the ground. We would have witnessed those persons practicing what they would not let them do. And that is when I guess we are wrong, is let them take over the ward or charge the ward, as we call it. But they do everything else. So I'm not sure if that takes place anywhere else in the world. It was a bone of contention with TTRNA. It's still on the law in our act. It still is, that facility is still there. What you have happening now, I mean, there's so many problems. I don't really try to focus on all the problems because we want to get depressed if you focus on all the problems. Let's look at the solutions. So getting this act revised is one of our major goals. It's the top of the agenda of stuff that we submitted to the Prime Minister and will be submitted to the opposition leader come Monday when we meet with them. We really need to get that act changed because we can't get higher salaries. We can't be called upon to fill key positions. We can't, a number of things that our colleagues are asking of us, we can't do because we have these multiple entry points from, in fact, you speak about specialist nurses at the higher level, postgraduate. Well, but it's not postgraduate because some nurses come out with certificates, so it's not a graduate certificate they have. We training higher level nurses, ICU nurses, dialysis nurses, trauma, what have you, at the certificate level. That is what we do. We training them at a certificate level. Upstairs a mall on Frederick Street, or in a nightclub in San Fernando, or with no library, no computer facilities, no security of tenure for the lecturers in these schools. So these lecturers just work 3 months. If they stop getting paid, they stop coming, and then the ministry finds some money, they send it their way. So it's a number of problems. So when you see TTRNA being very vocal and visible now, is because we need to get to the persons who can make the difference. And unfortunately, those persons, unfortunately, are not nursing personnel. Those persons are the politicians, the chief medical officer, the permanent secretaries. Those are the persons we are targeting now to really make a difference. Because without their decisive intervention, we would really reach nowhere.
Okay, sorry, Edie. Sorry to. I'm sure you have other things and lots of other things you can talk about. But let me just see, Caroline, are there any questions in the chat box?
Yes, Roger. There's lots of comments and thank you. A lot of people are agreeing with and giving examples of some of the things that have been said by Edie and Oscar, Dr. Ucho.
That's fine. I'm with colleagues.
I know. I'm just kidding. There's lots of examples, and I'm sure people can read the charts, but I can just have highlighted some questions that we had, and I suppose some of it may have been answered. One was that from the discussion that there's an argument clearly that after 5 years as an RN, that why isn't there, I guess, an accelerated program for the completion of a bachelor's? The other question was, is gender affecting nurse leadership? And have you been able to identify the barriers to leadership? A third question is, are there mentors on the shop floors to ensure that practice matches theory? And we have a question from Shelley McCletchy, who says, what is the model used for recruiting student nurses? Is there a probationary period for newly qualified nurses? What are some of the career aspirations for newly qualified nurses? And are there any further conversations about nurses qualifying at degree level? And I know some of that has come up, but those are just some of the questions that have come in. And we've got a lot of comments from people either giving examples of what has been discussed and agreeing generally.
Okay, lovely. So let me put some to our panelists, because that's what they have for in the last few minutes we have. The question around gender and barriers. So Oscar, is gender affecting nursing? You know, do you know anything about the percentage of males versus females in Trinidad and Tobago?
I don't have what the exact percentage is, but it would be extremely low. I would say it would be no more than about 5 to 8%. Is that female? It may be more in psych.
And is that an issue that needs to be flagged in terms of, is there a need to try and get more men into the profession, or are there other barriers where is restricting the type of nurses coming into? Is it salary a barrier? Is environment, is status, are all these things barriers?
No, I think it's more than gender. I think it has a lot to do with how persons practice at the clinical level. As a person in academia, I have a lot of my colleagues complaining to me saying, Dr. Ocho, it bothers me. I go on the ward and the nurses are just sitting at the desk. They wouldn't come on the ward rounds, you know, whereas, you know, I mean, how could a doctor make a ward round and the nurse is not part of the decision making to report as to what happened? So I think it's not a gender issue, but I think it's a case of how do we see ourselves and accept nurses stop thinking, well, I'm just a nurse, them is the doctor. Except we stop that kind of conversation and realize that we are integral to the kinds of decisions that are made. Further, we also need to recognize that it's a term that Rupert Jones uses all the time. And it's a video that I use in my ethics class when I used to teach ethics. Nurses eat their young. So that we function in an environment where I don't know. It's a kind of crab in a barrel. Sometimes we don't know how to celebrate each other, but we kind of fight each other. But to me, as a person who is just an RN, and I use the word just an RN, I don't have any post-basic training apart from education because that's my specialty in nursing. I was able to rise to the post of Chief Nursing Officer and receive respect. Now it could be at that level, being a male brings with it a different kind of respect than being a female. That I would identify. But at the clinical level and at the mid-level, I don't think it's about gender. I think it's about how we project ourselves as nurses.
Okay, lovely, thank you. And just the other one for Edie. Edie, in terms, there was a question about mentorship. Do students have a mentor on the ward who can, I don't know, sign off some practice books that they do to link the theory they would have learned in the classroom to what they're doing on the practice ward? Would you be able to answer this, Edie, or is this another one for Oscar?
Well, Dr. Ocho probably would know specifically to his school, but from Are you speaking about students, or are you
Yes,
speaking
students.
about?
So a student has come on the ward. Are they allocated a qualified nurse as their mentor for the length of their placement,
Okay.
who could do their, summative assessments or whatever you have?
Yeah, Dr. Ocho will be able to answer that, but they would have clinical instructors from the school. Some of the RHAs trying to organize preceptors to shadow these younger nurses. And they're seeing that because someone would have highlighted prior that you have a gap now. Despite there's a huge vacancy, I would estimate between in Northwest, North Central, and Southwest, you have at least 20 to 30% vacancy in nursing personnel. Graduated nurses take an average of 2 to 3 years to get employment. So think about this situation. The students who come in from COSTAT, particularly, they could take anywhere between 3 to 4 years up to 8, 10 years to get their qualification, because it's up to them to choose which course they want to do at any particular time. So it just goes on and goes on. We have a number of problems with that. I think the school is changing direction. They're seeing the benefits of cohorts and trying to keep everybody together, but they had experimented with the college model where you could just pick and choose which courses. So you end up having a lot of persons being in the program in excess of 8 years. So think about you in the program for 8 years. Your anatomy and physiology was done in the first 2 or 3 years. Your medication was done in the first around the 4th or 5th year, and then you are thrown. You were home after you graduated for 2, 3 years. So you come out onto the ward, and in some institutions, some of the RHAs, they will actually put you on the ward, and you could very well work alone on a ward in your first week in the institution. So forget mentoring, forget probationary period. You are left on the ward alone with a auxiliary staff, ENA or supportive staff, PCA. This is what goes on. Fortunately, not in every RHA. Some RHAs are very strict. Southwest, ERHA. Some RHAs are more flexible and not as stringent in some of their measures, because forget nursing, it's supposed to be a probationary period for any monthly paid employee who comes in the institution. Far less for a clinical person like a nurse. And that nurse gives medication, gives everything, performs. And we know mistakes are being made. Unfortunately, there's no statistics like you would get the number of errors. You can't get that information anywhere. We have been trying to do that ourselves, but you can go to the Ministry of Health website and find out how many errors or adverse events you had in a particular year. That information is hidden. That takes us back to all the other institutions that we haven't brought on, the Health Sector Accreditation Council, the Quality Council, all of the directorates of quality, all these institutions that's supposed to safeguard the public is not there 26 years on from health sector reform. All this information, all this work was done in the early 2000, 2001, 2002. All the documents are there, yet we have not gone on and implemented these important areas.
Sure. So, okay, Edie, sorry to cut you, but I want to give Ocho the last question, which came from Shelley. I know it was a long one. So Caroline, could you read it? I know it was about the model used for recruiting nurses.
Yeah,
can you repeat it for Oscar to respond to, please?
So it is, what is the model used for recruiting student nurses? And is there a probationary period for newly qualified nurses? What are some of the career aspirations for newly qualified nurses? And are there any further conversations about nurses qualifying at degree level?
Right, okay, number of questions. One, I am not aware of any clearly defined model of recruitment. In some institutions, they expect you to do an essay, and they use that as part of the recruitment. At the University of the West Indies, it is clear, we have been advised, if we want to do interviews, The interviews must be held before the assessment committee meets and make a decision, because if you make a decision if you want to interview after a decision is made, it is unethical. And sometimes you have a short window period to respond. So the basic requirement is you must have 5 subjects. Some institutions hold out for maths, some hold out for numeracy subject, English, a science, and 2 others. So it is the academic requirement.
Right.
And that's the basic model. Opportunities for completing a degree. At UWI, what we have done is that we have just developed a 1-year online course that will allow nurses who have an associate degree diploma certificate to come up to scratch with a bachelor's, and they can move on to specialty. There were 2 other parts to the question.
Probationary period.
No, there is no probationary period for nursing. You qualify. If you get employment, you hold the DDA key from the next day. What they have is the nurse internship now, which cannot be considered a probation because you are not qualified as an RN.
Right. And can I just clarify with the nursing intern? Those are nurses, well, they're students who fail their final exam. So,
or who would have completed their program of training but had not done the final licensing exam. Oh, and the other question dealt with career paths. Now, there are a number of career paths for nurses. Nurses can decide if they want to remain at the clinical level. One of the things we are looking at the university is to develop a number of clinical pathways at the master's level. If you want to go into education, you can become a clinical instructor, you can become a nurse educator, you can become a director of nursing. If you want to remain in administration, you can become head nurse, nursing supervisor, nurse manager, chief nursing officer.
Okay, lovely. So we've just gone the scheduled time by 3 minutes. Are there any other questions, Caroline? Because I want to wrap it up now.
No, I think that's fine. I think people can have a look, and I've captured all the comments and questions and examples that people have given. So we have that information which we can use and discuss. And there's actually been a request, will there be other webinars or another session and on these topics in particular? So I think maybe there's scope to do a bit more, because I think that the time just went away with us.
Yes, so, actually, agree.
That's fine.
Okay, so we will do other webinars. We, as people know, we are varying them a bit and getting other subjects, and this, we focused on nursing today, but 2 weeks ago we had a couple of doctors. We did surgery and cardiology. So we will change the topic. We do want to do one on mental health. We're just trying to get the right, panelists, because it's a subject I think we need to discuss, not just from a nursing point of view, but just the entire mental health practice, Trinidad and Tobago. So once we could get the right people to be on the panel, we will arrange. So I just want to end by saying thank you to our panelists. Thank you, Edie. Thank you, Oscar. It's been very good. It's been very engaging. Of course, there's so much things we talked about that we could talk a lot more on leadership, education, employment, career paths, things like, the reviewing the Nursing Personnel Act, all these things. Politics seem to play a big part in nursing, if you all don't mind me saying, actually, although, I think a lot of the words used were, waiting on political decisions or political decisions impacting on the nursing profession. So we'll see how that pans out. So I want to end by saying thank you also to the participants for using your time for dialing in. I hope you enjoyed the session. I know I did. We will make this recording available as soon as possible. So once again, I will end by saying thank you. Enjoy the rest of your evening and look forward to having you on our future webinars. Thank you all.
My pleasure.
Take care. Take care. Yeah.
Bye.
Yeah.
Bye.
Thanks all.
Thank you, everyone.
Yeah. Bye.
Bye-bye. Thanks a lot.
Bye.
Bye.
Bye.